Welcome to Goal Getter, the AAP Physiotherapy podcast. My name is Jen Panteluk, and I'm the CEO of the Alberta Association of Physiotherapy. This show explores the power of physiotherapy, helping individuals move, heal, and thrive. Let's get moving. Today, we're talking about a topic many of us don't think enough about: pelvic health, and framing it around the question, what don't I know that I don't know? Joining us today, we have Gail Hume, a pelvic health physiotherapist with years of clinical experience, to help us uncover the things we didn't know we needed to know. Gail, welcome to the podcast.
Thanks for having me, Jen.
To start us off, could you share a little bit about your background and your passion for pelvic health?
Yeah, I think my passion started a long time ago when I was still in university. I have been a physio for 25 years, and what I noticed when I was in university that we often were told that we couldn't do this or that when someone was pregnant. And I constantly questioned that. I thought, why are we not doing this? Why can't we do something simple like a hot pack for someone who's pregnant? And this was a long time ago. And things have changed. But it's right then and there where I went, I think this is where I would like to make some changes. And I manifested that. Essentially, I wrote down had a little exercise. I wrote down what I wanted to sort of do. And here we are. 19 years later, I do have a practice that do treat men, of course, as well as a lot of women and their children. And really, a lot of that has been born around doing better physiotherapy for women.
That is so important. And I was kind of smiling when you were saying all the things they tell people that they can't do when they're pregnant. I remember challenging so many of those. I'm like, well, show me, like, what's the research about why I can't do this or I can't do that? So, pelvic health, as you know, is much broader than most people realize. Could you speak a little bit to some of the gaps in the pelvic health knowledge?
Yeah, absolutely. Things have really exploded in the last decade, maybe a little bit longer in terms of pelvic health knowledge, not just in practitioners, but a lot more information online and with socials. I think one of the things we need to acknowledge, and when we think about pelvic health, we're often thinking about women, females. However, there is a lot to be done for men, for children, for transgender folks as well. There just happens to be fewer pelvic health practitioners who are in these areas. So maybe they don't get as much screen time or as much notice. But I do think that's a really important place. And where I land with my female population is that we often talk about what's happening with their children if they have a concern with what's going on and what's happening maybe with the males in their life, and are able to sort of refer them and get them and their family members and friends some additional help. The other thing that I think also gets sort of misconstrued a little bit is coining pelvic health with women's health. And I think it's important to discern the difference. Women's health is very broadly um, kind of knowledged as breast health, it can be cardiac health. Bone health is a huge piece of women's health. Even more of the genital reproductive oncology kind of health and care that can be provided. And there are some really excellent physiotherapists and other practitioners who work in the women's health side of things. So, I use that term even when we were talking about like where was my passion was women's health, but really where I narrowed into is pelvic health, but it's a huge big spectrum uh, when we speak about that.
Yeah, exactly. It's kind of like that, again, going back to the whole body when you're considering healthcare as a whole.
Yeah.
You mentioned that you specifically narrowed in on pelvic health with the work that you're doing. What areas tend to be overlooked or maybe misunderstood in this area?
The area of pelvic pain, I think, is a really misunderstood aspect of pelvic health. Uh, Definitely, it can be really specific to vaginal or perineum pain, but I'm also speaking to sort of that mysterious pain that can come from different sources in the body. Um, Essentially, I think practitioners, whether it's family doctors or even specialists in the medical field, they're not exactly sure where else to refer their patients for if they've had some different sort of diagnostic tests and they're still unsure about how to help them. What we find and what I found early in my career in the pelvic health world was I was getting referrals because someone was having some tricky hip pain or some low back pain, and there was some maybe some referral patterns. And I was kind of like that last ditch effort to see, well, if we can't find it here or there, maybe they can find it, within this place of this pelvis. And I think the pain itself can be mysterious, but I think the area, the pelvic area, when we're talking about females with vaginas, and that whole zone tends to get kind of, it almost is a little bit taboo even for medical professionals. So I think that gets really misunderstood. We can do so much. And I actually really appreciate people saying, I don't know what else to do. So maybe it's a pelvic health issue. And I agree. It's not always the pelvic health issue, but with my knowledge in orthopedics and neurology and what pain science is all about, we can actually, you know, treat the whole person and the whole body, and we can understand a little bit better where maybe their source is coming from, and perhaps we're treating from the perspective of the pelvis in some of those cases.
So you mentioned that sometimes pelvic health seems to be a bit of a taboo topic, an area where like you get referred to as a last ditch effort. Why do you think pelvic health education is so limited, both for the public but also for healthcare providers?
I don't know why. I think it is because there are a lot of different interpretations as to what is okay to talk about and what isn't okay to talk about. Maybe that's cultural. Maybe that's just how each of us as individuals have been raised, or those kinds of things. Um, I think the education is getting so much better. There wasn't as much many years ago, 19, 20 years ago. And even before that, there were some real trailblazers in our profession as physios who really stepped up to the plate and started to look to those boundaries of what we can do. Um, but back to the question of why and the tabooness. The problem I think is that there's a lot of words that aren't used. They're usually used as euphemisms. We're not maybe speaking specific anatomy kinds of things, and it's just embarrassing. It can be really embarrassing for a practitioner. Potentially, as well as certainly patients coming in and not wanting to use real terms, or maybe not even knowing what the real terms are. And then that gets confusing. I think it's just about making all of these parts normal. It's an important place to start a conversation sometimes, and really just sort of taking away, the embarrassment level. We always say that there's never too much information for us. I think any pelvic physio will say, nope, never TMI. You just tell me as much as you want, use the words you want, and I will describe to you where I think you're describing it, and then we can have a common language. And when we start talking like that, then it becomes, we're just on the same playing field. We have the same communication, we understand what we're doing, and the patient understands what's happening. And now that really empowers them, and that helps a lot with the fear factor. So, I think healthcare providers are doing better, and I think we still have to do better and better for our patients and make it an okay conversation.
Well, and I think to your point on the terminology, I think that's a big one as well. And being able to have the conversation and empower them to be able to talk about what's happening within their own bodies, but be on the same page as the healthcare provider.
I know. Well,
I think that's
my own
huge.
experience when I was giving birth to my first child, really well-meaning nurse said, "Push to your bum." And I put my hand up between breasts, and I'm like, I think you mean my vagina, like, because that's a totally different place, right? And I took that, and I'm like, I'm always describing that. Like, I always want to be really specific with what we're talking about. And the word bum could mean anything. It can mean glutes for in one context. It could mean around the anus in another. It could, so that terminology, I think, is really important, that we do have a shared meaning about what words we're using.
Yeah, exactly.
Mhm.
So building off of maybe some of those limitations of education, and you'd mentioned it earlier, a lot of times people think about pelvic health as only bladder control. Could you maybe expand on what are some other concerns pelvic health physiotherapists might commonly address when a patient walks in their door?
So, absolutely, bladder control is a common kind of complaint that women will have, but it may not be their primary area of concern. And when we dive a little bit deeper, we can find that there maybe are some other issues that have been longer standing for them or are actually quite problematic, but they're here because they understand pelvic health helps bladders. So bladders can certainly have issues with control, and there's a whole facet of like how do we treat that and why. But bladders can also be painful, so that's an important area that we work within. We work also within sexual dysfunction, and dysfunction can mean a lot of different things. So that could be sensation, it could be lack of orgasm, lack of enjoyment, but it also could be into pain. So there's a lot of different sort of questions that we ask when we hear the word pain with intercourse. We're asking about when and where and for how long, and those kinds of questions that sort of give us that source of where we're going to go look next. Tailbones are part of the pelvis. It's actually a really big area, uh, because people fall often, or they've had falls before, or when they were a child. And there can be some things that we have to look at from our access point is just what I talk about when I'm working with females. So our access point sometimes can be a vaginal access point, it can be also a rectal point, where we can really feel that tailbone and give it a good test, and see if there's anything we can do mechanically for them that way. And then on that note, even bowels, and I think bowel control and even how to evacuate and eliminate those, it's actually a really big piece of what we talk about and what we treat. And I think there's way fewer women who are necessarily booking an appointment specifically for that. I mean, definitely, but it is something we probably talk about uh, on average more often with most patients. And then the other one would be pelvic organ prolapse. Um, these women will definitely come specifically for prolapse. And those are areas that I think are getting more notoriety of what we can help women with.
So, for listeners who maybe are new to this topic, could you tell us a little bit more about what pelvic organ prolapse means?
For sure. What it doesn't mean is that it does not mean that the organ itself is necessarily falling out of their body. And and there are some caveats to that comment, but especially when we talk about bladder prolapse, we have a much better way of saying it now, and it's probably easier, or at least terminology around sort of what is prolapsing. Um, but essentially, it is the organ falling into a space that they should not be. And the vagina is a structure, and we do call the front wall of the vagina, and I'm going to talk with my hands, but I'm going to bring out Iris, um, and explain what I'm talking about. I always
I
talk
love that
with
you have a
my.
visual.
Yeah, thank you. And now she actually has a pessary in here already, which we'll probably talk about. But so this is sort of the vulva, and this being the opening of the vagina. It's not the vagina itself, by the way. The front part here is called an introitus, so kind of like the door to the vagina. And then this canal that you're seeing here, which of course has lots of structure. If one is sitting, it kind of sits like this, but if one was standing, it would be like so. But I'm going to put it on this orientation so we can kind of understand. So the structure of the vaginal canal, this being the front or the anterior, and the bladder actually sits on top here. And then there's a back wall posterior. And then what runs parallel to that is the rectum. So, and then on top of this, this model has kind of essentially had a hysterectomy, but has left the cervix. Okay, so the cervix is there, but the uterus would sit up through here. And why that is important is sort of this terminology of prolapse. So what happens typically is the wall itself gives, and the bladder will sort of sink in towards the wall, and we call that an anterior vaginal wall prolapse. And that's why I'm saying it's a bit of a better word than a cystocele or a bladder prolapse, which are all the same word, meaning the same thing. But when people hear my bladder's falling down, it's easy to think that your bladder is falling out. But it is really the wall of the vagina that has lost some of its structural support. It could be some of the ligamentous support. It could be some of the fascial support. Um, it could be in some ways some of the muscular support as well. But remember, pelvic floor muscles live in another plane here. So we're just talking about the structure of the vagina. So that's a very long-winded way of describing what a prolapse is. And you could think of it like a hernia, like where something's that's essentially why they'll use the word seal, like cystocele, rectocele, because that seal word means essentially hernia. So it's something falling down or pouching down. And I think most of us can understand a hernia. And you might want to think about prolapse in some ways being very, very similar.
So you mentioned the fear of, organs falling out if someone hears that they have prolapse. Are there any other common misperceptions or fears around this terminology or like the idea of prolapse?
Oh, I mean, so much. I mean, it can actually be a really devastating diagnosis for a lot of women, if not all women. When they hear that. I think in some ways, um, if they're having a prolapse that's quite symptomatic, and we should probably talk about that a little bit as well, because
Mhm.
there is some norms that we should also dispel, where there may be some evidence of some prolapse, and maybe not really clinically relevant in lots of ways. But when she's experiencing prolapse symptoms, which is a heaviness or specifically a bulge, and she can feel it kind of at that entrance of the vagina where she can feel, or she takes a mirror and she sees it. It can also be very validating to get a diagnosis, because it can be concerning to have this so-called mass coming down, and there's a lot of concern about what is that, if she's not doesn't know, as most women don't understand, that the walls themselves can kind of collapse, that they're just feeling, a ball or a balloon kind of feeling. And that can be really scary. So sometimes this can be really validating, but, oftentimes it ends up being really, um, they're just kind of mourning a little bit the loss of what they think about their sexuality. They may also have some voiding difficulties, on either end, whether it's bladder or bowel. So I think teaching women kind of the anatomy and understanding, and sort of just our ability to also measure really specifically what's happening, and giving them some of this advice, that does take away that fear of this, strange diagnosis that they've received. And they also think that things are going to get significantly worse. And that's it. That fear builds in a whole another layer for us to actually work through, right? So we're
Mhm.
often trying to undo those kinds of fearful body responses, and trying to sort of move her into sort of a recovery place, rather than just a freeze, and from fear.
Right. And you had mentioned around the norms, like there are some
Yeah.
things that are Do you wanna, unpack that one
Yeah,
a little bit more too?
totally. So we tend to use these days, and I think the more appropriate sort of system that we're working with is called the POPQ system. And so there are a couple of different ways that someone could be diagnosed. But the POPQ uses, believe it or not, a pop Q stick that it might be hard to see, but there are increments on here. And we take essentially 9+ different measurements within the vaginal canal, with different reference points in the top wall, the back wall, where the cervix is. And we understand what we do this at rest, but we also, most of the measurements are done under strain. So we want to see what happens to these tissues under maximum distress, essentially. Um, and the fun fact is, we've got stages, but the fun fact is that we've got 0, which used to be called no prolapse, and 1 would be mild prolapse. But the research is showing us that 50% of women, 20-year-old women who've never had a baby, will be stage 1. So I think that's fantastic news. And I think any of us pelvic physios should really, or other pelvic providers should really hear that out, because if we're seeing just sort of a normal variant of movement, and maybe a little bit on the heels of, is there some hypermobility? Is there, is just this person's tissue, all of those factors put in there. And if we say to them, you have a stage 1, front vaginal wall, anterior vaginal wall prolapse. And really, she has no symptoms. It really isn't impacting anything. And it really is considered normal in half the population who would otherwise not be considered at risk for prolapse. Why are we saying that? That is unnecessary information. So I love that tidbit of information, and it really, we have to kind of maybe look at, now 0 isn't just normal, 1 is super normal. That's even normal in half the population of those who haven't had a baby. So if we're seeing that there, and if we then see a woman who's had 2 babies and she's coming in for something else, and we are doing our exam and we're finding a stage 1 prolapse, that's not necessarily something that we need to treat, because there's not a problem. She's not symptomatic. It's within a normal range. Um, and I think that can be really empowering for us to be able to say to women, this is, you're within a normal range, and there may be some risk factors that we're going to look at depending on what you tell me. We're going to try to mitigate those risk factors, and build up your various different repertoires of what we think is important for you, not just strength. So I'm careful not to say we're just going to strengthen things, because it's not just about that. um, yeah, so I think that that's a huge component of understanding where research goes as well, and that really drives us,
Yeah,
I think, in physio, doesn't it? Right, we want to have
it
this
does.
evidence, and that's some really strong evidence right there, that we don't have to over pathologize prolapse.
So many questions, Gail, so many
Yeah, sorry.
questions. No, no, no. I'm just trying to think. So you mentioned, a 20-year-old who's never had a baby before,
Mhm.
not considered at risk. Which populations, are more at risk, to
Yes.
experience prolapse?
Yeah, absolutely. Okay, so we where shall I start? If we are talking about those who are in the childbearing years and there's still a menstrual cycle going on, we are looking at 2 or more vaginal deliveries. Pregnancy can also be a risk factor. And I do not want this, though, to be taken that um, we should have C-sections or those kinds of things, because everything comes with its own sort of set of potential risks that go along with each of those kinds of things. But that's a risk factor. If you have a chronic persistent cough, that really can, over time, start to create some of the weakening areas that we're talking about in terms of ligamentous support and fascial support. I think the big one is constipation. And I say this so much in my treatment rooms when I get up on a little soapbox. I'm like, I really think we should talk to young girls, particularly talk about constipation management, making sure that this is not a lifelong process. And, it is just a big piece, because if once, twice a day, or even a couple times a week, you're straining significantly to pass stool, that you've almost got to think about this structure kind of like, I relate to ankle or knee ligament injuries. Like if we're stressing and straining all the time, it's going to be a little bit less resilient when it comes down to that accumulated effect. So constipation is a big one. That cough, because that's that intra-abdominal pressure. um, those are probably really the big ones. The other thing that can happen is increased abdominal weight, and that's unfortunately where we put our weight as we start to hit perimenopause and menopause. But that can also increase the risk, as well as, at least for symptoms, right? It just puts more pressure. And then in menopause, here's another fun fact. The research is directing us to say that a woman who has, say, a stage 2 prolapse, so and this differs, and this gets a little technical, but a stage 1 uterine prolapse would equate to the same as a stage 2 bladder prolapse, or an anterior wall. And it's really just our measurements and what tends to sort of be symptomatic, and it's essentially where the tissue lies within or outside of the vagina, in terms of how many centimeters we're counting. But essentially, if we just say sort of like the bladder, the front wall, a stage 2, the research is showing is it does not increase in degree of severity of that prolapse when we hit menopause, but something changes, and we tend to get symptomatic. So I think it would be a really easy cross sectional look at sort of where my clinic is, where what the average age of women coming in with prolapse, and they would tend to be around that 50-55 mark. And we become more symptomatic. So the prolapse itself is not worsening. So they've actually done those retroactive sort of studies, and then they saw like it did not get worse, but her symptoms all of a sudden got worse. So that means estrogen has probably fallen off, that vaginal estrogen, and the vaginal estrogen receptors live in the first third of the vagina itself. So if we've got, let me come back to Iris. And I had a pessary in there, so I've just taken the pessary out. So the first third of the vagina here gets more sensitized because it's lost the estrogen. And then if we've got something that was sitting here before, wasn't a bother, but now it's sitting there against this estrogen starved tissue, it's going to become way more notable. It will feel maybe more bothersome to her, just because of that. That's actually pretty easy. We do love having vaginal estrogen on board, and that's something we don't obviously prescribe, but that is a great communication and a bring forward of their family doctor, any of their other sort of medical professionals that are prescribing for them, not nurse practitioner, and those symptoms can go away essentially with a treatment like that. And if that's all she's concerned with, then often problem solved. So those are the kind of the risk factors, kind of sort of go through our life cycle a little bit that way.
So you're mentioning that sometimes when people, hit more of that perimenopause, menopausal age, the symptoms start to really come out. What are some of the other
Mhm.
are there other symptoms or signs outside of really just feeling that sensation that a woman might notice?
Yeah, and this is where we come back to, maybe the bladder becomes that primary reason why they come in, but they might find
Mm.
it difficult to completely empty. Or they may find they void their bladder, so they pee, and then 5 minutes later they feel like they have to go again. So there can be that kind of issue. And the same thing, so we've been sort of talking about that front wall, but if the back wall, which is a very common thing, which is called a rectocele, let me diverge for a minute. It is not called a rectal prolapse. And lots of people come in, they say, well, this is a bladder prolapse. This must be a rectal prolapse on the back wall. But a rectal prolapse is a different story altogether. A rectal prolapse comes from the anus and is a bit of a column that protrudes that way, where this is truly a rectocele or a posterior vaginal wall. And that what that means, and why I'm getting to my point here, is that if we've got a little looseness at the back here and part of the rectum is pouching into the vagina, she may find that she has to actually manually splint to have a good bowel movement. So think of it like there's stool that kind of gets trapped a little bit and she does not feel great about the bowel movement. She still has a sensation she could still go, and so that kind of incompleteness of bowel emptying, or even just sort of this intuitive consideration. So, see if I can kind of give you a little, there's a little bulge there. So, she may feel like when she's on the toilet, she may want to push backward a little bit, and then she has a really complete bowel movement. So, those are some of the functional um, sort of impairments that can happen with prolapse. But I think the big ones is really, and most importantly, is kind of that bulge, that feeling something falling down, or sometimes women will describe it like it feels like I got a tampon in sideways. It just doesn't feel quite right. But they can also have back pain. They can have issues in their abdomen. It might feel a little bit sore. It could be the low back. And that's where we love to tie in our orthopedic knowledge and either rule that out or rule that in as part of the diagnosis that we're making from a pelvic perspective.
Right, and it goes back to that understanding how all the different systems work to be able to tie it in when you're working with the patient.
Yeah, I talk about orthopedics a lot. I'm just like that's like my first sort of place as a physio. I feel like it's just foundational. And I think, whether you're the active treater, and I combine my treatments all the time where it's an orthopedic session that we have put into the context of her pelvic health. But a good knowledge of neurology is huge as well. And we deal with nerves constantly in this pelvic area. And Jen, that probably actually takes us back to sort of, a question about using maybe euphemisms or not quite understanding. But, what we learned in physio school were red flags. And there's something that we would ask patients, and it's called, do you have any saddle paresthesia? And do you know, well, I mean, you ride bikes, so you know what the saddle area is, but not everyone understands that. And I will also say that it's a red flag. It can mean really serious, significant medical issue when it comes to something going on with the nerves in their back and those kinds of things. So it's not to be taken lightly. We actually test these areas as a primary step of our assessment. We're assessing like touch around the vulvar, so the saddle area is around the perineum, anywhere that you would sort of sit on. But that's a huge, neurological orthopedic consideration that isn't something I'm necessarily treating primarily. If I see that, and if we are getting some different sensory or muscular or sort of motor control issues as I'm doing my perineal scan, that is a let's get you off to, it might even be emergency room if we're thinking about something like cauda syndrome, which is a significant injury that can impact how your bladder control is and your bowel control, but because not because your muscles, but because of the neurological system. So having a huge breadth of that sort of understanding of all of the multitude of different kinds of conditions that can present is, I think, really, really valuable. And we are the ones who are actually testing. We're not just asking the question, right? We are testing.
Right. Someone comes into the clinic and they are diagnosed with a pelvic organ prolapse of some sort. Um, let's dive into like how can physiotherapy help someone? And what are some of those management techniques that you might look to utilize for someone coming in with pelvic organ prolapse?
Yeah. And you know what? It is. It so depends on who is presenting to us and what their complaints are and where they are in their life. Because we don't have a cookie cutter plan. Everyone doesn't just get this or that or the other thing. And I think the first thing that I do is I ask, I listen, I reiterate, what is your main goal? What is the thing that really brought you in today? What is the thing or the things that you really want to address? Um, because I may look at, some of my assessment findings and go, oh, this is the way I want to go. But if what's really meaningful to her is the fact that she's running and she feels heaviness 2 kilometers into her 5-10K run, um you know are we going to necessarily wait 8 to 12 weeks for a strengthening program to really work its magic necessarily, or would that be the first line that we think we should do? For me as a pes refitter, I would go for this particular patient. I would introduce the concept of a pessary for her, if it seemed medically appropriate as well. I would then add in some hypopressives, maybe, which is a sort of a decrease of intra-abdominal pressure technique that one can learn. And we're probably, depending, age and what the function is, but we'll probably add in some pelvic floor strengthening. But I would also add in, the rest of her core as well. Um, if someone is coming in and they've had prolapse, and again, it doesn't matter which compartment, whether it's the anterior, posterior, or the uterine. But she's coughing and she says, I struggle with constipation. I'm having such a hard time eliminating. When I go to the bathroom, it's just such a struggle. I would actually probably go straight to some techniques and some toileting ideas to ease that discomfort right away. Probably, we love talking about getting your feet up on the squatty potty. Using her mechanics to an advantage, maybe teach her how to perineal splint, talk about fiber, talk about water intake, just sort of that kind of gamut. um, and I think we've already touched on someone who's postmenopausal, and you know and this would be better even if I knew her from before, where I knew what her prolapse was 5 years ago. And then she comes in, and this actually happens often enough. She comes in now, she's postmenopausal, it's 5 years later, and like, oh, all the things we did before, uh they don't, I feel like it's worsening, and I test her and it's not any worse, because we know that for the large majority of women, the prolapse doesn't actually increase in that time period, but her symptoms are. So that might be a letter to her doctor asking to consider vaginal estrogen as one of her main treatment options. Yeah. So those are, like, this, it kind of goes everywhere. And to be
Right.
honest with you, I use a lot of my other techniques. Like, I use IMS a lot in my world. Why? Because there is such a strong orthopedic connection. Maybe thinking about the runner in particular. Like, what other areas of her pelvis are we wanting to see if we can kind of balance a little bit more? Does she also have some, long history of ITB sort of issues? All the things that kind of go along with it. And I think they speak to each other, right? All of these kinds of things and the adaptations that our body take on. We kind of, sometimes we have to kind of go back a little bit too.
Right. Well, and I think that's the beauty of like the profession and physiotherapy as a whole, right? It's the assessment, it's taking into all the consideration, the history that helps you to really build that plan moving forward for the patient that's very patient centric, and it speaks to, and you mentioned it, it speaks to their goals and what it is they want to do, or what they want to get back to doing sometimes.
Absolutely. Yeah, I think we have to remember they're in control, they're in charge, and they look to us to guide and to use our best judgment, which is just, super important. But we also really want to reflect it for them, like, where is this, where do you want to go with this, and what else can we look at so we can get the whole system in charge. um And I kind of alluded to kind of some other exercises outside of the pelvic floor. And that's where I talk about the core four often, which, our diaphragm, the transverse abs, the pelvic floor, and the deep spinal muscles, the multifidi. And it's easy to kind of just speak about it, but it's so much more important to put it into practice for people. And that's where we then start to build maybe their exercise program, the things that they can do at home that is, not just those four muscles, but, building on top of that, some of the big prime movers as well. And it just starts talking about their general health, and that's where we move them forward into what their other goals are, because they may be coming in and they're postpartum 3 months. Oh, this happens lots. 3 months postpartum, and I'm going to be running that marathon in about, you know 5 more months. Where are we at? That kind of thing. And so if that's their goal, then we work towards that. And it might include a whole lot of quad strengthening as well as what's happening in their pelvic region postpartum.
Right. Yeah, it's understanding, like, the
Yeah.
whole system. You had mentioned, when you with your example of the runner,
Hmm.
2K in of a to a 5K run, that you would maybe recommend, a pessary fitting. Let's dive into that a little bit. I feel like this is a
They're,
topic that not a
they're
lot of
waiting.
people talk
I
about.
know. They're waiting to be shown. Well, first, let's talk about what the heck a pessary is.
Yes.
So, a pessary is a medical device, number one. So, it is a intravaginal support that they're made of silicone, generally speaking. And depending on what we're finding in our assessment and what the complaints are, we will find different styles, and we certainly will use sizing based on our POP-Q and our digit exams in the vagina, and we will then use it as a support. So there's been a, a lot of great analogies on what a pessary is. So a lot of people will say, well, that's my sports bra. I would probably not go for a run without the sports bra, which is so very true. I also think of it like an ankle brace or a knee brace. And in fact, it is very much the same. So as much as it's like a sports bra, but that's pretty like, most people would wear that. But if you had a deficit in your ACL, you very much might be putting an ankle brace on, or a knee brace on, or an ankle brace if you've had recurrent ankle sprains. So that's how I position it to women, because it's really, I would like to decrease the threat of this. And there definitely can be this concept that um, it's only for older people or those kinds of things. And I'd like to dispel those myths. So that's what it is. It's an intravaginal support. So the one I have in my hand is, if you can see it, it's not a very big one, to be honest with you. They fold. Most of them will fold or compress in some way, and then they get inserted. And we teach the patient, actually, once we find the right one for her, to self-manage, as for the most part. So she's putting it in, and then she's removing it when she doesn't need it, or when she needs a break from it. Again, that goes into a lot of details. Some women will just put it in, use it for their activity. This might be a good example. This is called an incontinence dish, and it has a little knob. And when I had it inside of the Iris model, it was sitting such the knob would actually hold up the urethra neck. So sometimes that's what happens with incontinence during running, is we need that little bit of support to kind of keep that from funneling open from the bladder. So the knob is useful for incontinence. And this one actually has a little bit of a holding capacity to kind of support both the cervix as well as the anterior vaginal wall. So it sort of sits along the front part, if you will. And when I put it in, it looks like it takes up the whole space, but its support is meant to be on the front. Um, my little purple one here is not that little. It's a little bit bigger, but again, it's, all sizes. And sometimes this is really just about vaginal length. It would fold and it would go in. And you can see this one actually is a little bit more flat, but it has a larger knob. And again, more for incontinence and for bladder support with this one. I have another one. This is called a Gellhorn. I didn't bring all of mine. There's so many. But this one actually would sit more kind of in this kind of aspect. And it's great for the front wall, but it's also really good to hold up the cervix and the uterus that might be descending a little bit. Um, so these are the Gellhorns. Actually, they look a little scarier than what they are. They're fairly user friendly, and they just do a really good job of. I kind of think of the cervix like the ceiling. So if you can hold up your ceiling, then your walls also might have a little bit more structural integrity as well, right? So that's why that one is
Right.
orientated in that direction.
And are there certain instances where you may recommend a pessary more often than not for, an individual?
Well, yeah,
Personal preference or
yeah, I mean, sometimes people are coming specifically for it. And so
okay.
on rare occasions, we might say that you're not a good candidate, yet. We may want to, if we see a lot of dryness or the tissue doesn't look as healthy as it could be, that again, that's a collaboration with the doctor, the gynecologist asking for maybe some adjunctive therapies to go along with it, like a vaginal estrogen, for example. Um, and some women come in and they say, I'm doing everything else I can so I don't have a pessary. Now, that might mean that she doesn't understand how far a pessary has come, if they have some preconceived sort of notions about that. But, we might come around to that conversation at some point, but sometimes they don't want it. And sometimes they want to go straight to surgery. So we're kind of doing some prehab, and they're saying, I don't want anything else. I just do really want to have surgery, but I want some kind of management before that. So pessaries can be used as a management tool, as an interim. It could be sort of something that someone uses just for their activity to reduce their symptoms. And sometimes we're using it because it just takes care of everything. And it's an easy solution that they can self manage. And it doesn't involve all of the risks that surgery would involve. Um, but I think your point is that I think we're finding we're more likely now to consider the idea, not all postpartum women, but certainly a postpartum woman, because we know there's going to be some change and so forth. So we're not trying to again over pathologize, but there is kind of this concept as we keep learning from our own clinical experience, is saying maybe we could support her vaginal structure now as she's recovering from childbirth, reduce her symptoms primarily, but also see if we can change how the tissues kind of support the tissues, if you will. Think of it like an acute knee injury. In order to do the everyday things, there may be that knee brace, sorry, that goes along with that injury. I always talk about my ankle because my ankle is a major thing in my life that I've had made, a lot of things, and I just relate it all the time. Like, okay, well, wear an ankle brace when it's sore. Wear it when I play sports. I'll do my other parts too, but that's an important piece. So, but postpartum, we're finding maybe we can. There's nothing out there yet for research, and I think that's the new sort of consideration is what if a certain subgroup of women, if they are presenting a certain way and if they're having certain symptoms, are they really good candidates to do kind of like a prophylactic pessary fitting and see what they're like a year or 2 years later, having done that earlier than we may have done in prior years. And I have some high hopes for that because I actually think we can have great tissue adaptation from that. And maybe we would see longer yet when, you know, she's in her 50s, in her 70s. Have we done a great job by doing that early on in her 30s? And that she doesn't have to wear it anymore, right? So that wouldn't be a lifelong wear. It would be a short period of time.
Right. Kind of almost like in a way like a prevention step.
Totally. And that's the kind of the direction that really excites me. Going, okay, we know we can really help women in the now, but what is it that we can do to be even more preventative? Because that's the name of our game in lots of ways as physios. How do we know use our knowledge, and how can we put that into practice that really does, prevent, surgeries down the road and prevent other things that are kind of healthcare costing, right?
Yeah, absolutely. And I think it's encouraging. I know I was at a presentation a little while ago, and just to see more money being invested into women's health and women's health research as a whole, we're a little bit behind on that. And so it is encouraging to see, more people thinking about it, more resources being invested so we can explore some of these different paths forward.
Such an inequity that I think women have. Maybe that goes back to the start of my passion as well. What the heck? There's 51% of the population is female. And, we just should serve ourselves so much better. And yeah, it just, let's invest in that. Let's get better research. Let's make it a priority,
Mhm.
and not always an afterthought. Yeah, and we could go on with comparisons on how the health system doesn't hasn't always seen, um women as, well, sometimes test subjects that maybe aren't super ethical way back when, but also just kind of listening to the concern that is not, that does come from something that can be easily treated rather than, dismissing.
Right. Absolutely.
Hmm.
And on that point, like, what information do you wish that all women knew about pelvic health, like long before any problems occur?
Yeah. I got to go back to bowel movements. Like I said, I think if we had sort of a good program, we have a, sexual education program, um, for, school age children. We should be talking about proper toileting habits, things like, you know, eating foods that are better for, stool bulking, easier to pass bowel movements, so we're not straining. And I guess I put girls in this because of the kind of risk factor when we think about prolapse, but also, boys and men and all of the things that go along. So as a general population, we should definitely talk about that. Um, we should go to the bathroom when when our body tells us to. That's really hard for kids. And I think it's obviously hard for teachers and administration because sometimes kids use that as an excuse, to not necessarily go to the bathroom. But it's a problem if they have to go and they've been told they can't go. But same thing with us adults, and we're in certain jobs that we see one patient from the next to the next, and we're not taking our breaks that we should. And we really should schedule that. It should be a priority. So if your body's telling you, especially to have a bowel movement, listen to it and, reply, and by going to the bathroom, and, voiding times for your bladder, roughly 3 hours. We don't get really hung up about 2.5 now and 4.5 another time, but roughly on average about 3ish hours. If you haven't went pee all day, we should really think about that. We should also move our bodies, and that's really hard, right? Sometimes it's just the nature of the work, but if we can actually move more, it would make a huge difference. And I have a bit of a little side note of a story when I worked in a nursing home. The primary problem, often that was a cascade of other issues, um, is bowel impaction. So it's a huge problem in nursing homes, especially if they're not, they need help walking or moving. And I think that's a big place that we can play a little bit more of a role and encourage residents to do various different things, or they can't make it to the bathroom on their own. They have to call and they're not necessarily getting it. But if they don't, that feeling of a bowel movement can pass, but you haven't actually passed any stool, and it would continue and continue and continue. And a bowel impaction is a serious medical emergency, huge medical emergency. So something that seems so simple that can really impact somebody's life, I think, in a dangerous way is important. So that's my little tangent on movement and listening to
Mhm.
bowel movements in all age categories. And also, I think body weight, keeping that in check. We already know, it can impact us around that perimenopausal sort of stage. It's not easy for any one of us to manage that, but I think it is something we should make sure it doesn't get sort of, um, take get kind of have its own sort of path where we're like, oh, but now we have to lose a whole lot more. Like we should check it without being obsessive about it. And I think that's also really difficult in our culture and all the things that we want to have body positivity. But most women that I see, and if they come back and they say, I'm feeling better, I lost like 10 pounds, and it's a huge relief to them. And that's where we refer, to dietitians and family doctors and nurse practitioners, because there may be some other ways that can really help someone kind of get on top of those kinds of things. So those would be my key points.
Is there anything I'm just thinking about back to this taboo topic, people still aren't necessarily always comfortable even bringing up some of the challenges they're having with a healthcare practitioner. Is there anything that, you can leave patients with, to help them feel more empowered to ask or even to advocate when they're seeking pelvic health support?
Well, I think it really is to open up that conversation. Perhaps educate themselves a little bit ahead of time so that they feel a little bit more empowered walking to the door in case their provider is using language that they maybe don't hear that often. It's not necessarily anatomical that they're thinking of. Um, Educating themselves, though, appropriately. uh, there's so much out there in social media, and there are a lot of people who know what they're talking about. But I do say caution. If you have a 15-second reel, they're not talking about you specifically. So what they're suggesting is a good, easy, quick fix isn't necessarily what's going to work for every single person. So the person who wants to go and have that conversation, have it first. Don't go and try some quick fixes. It's not necessarily, the right path for you. Um, yeah, and just beyond that, ask the questions. Ask the questions of your provider. And I can speak from pelvic floor physios, or pelvic health. That term is interchangeable, by the way. We don't know what to call ourselves sometimes, and it's not just about the floor or the muscle. So that's why we say pelvic health, generally speaking. But there's never too much, and there's never, you know, we don't want women to feel embarrassed. We want them to feel comfortable and safe. And so, even if something embarrassing happens, like they leak when they cough while I'm testing, it's okay. We want to see those things. It's like eliciting, does that hurt? We can understand what's happening with that. So, um, we're really all fine with anything that can be asked and said in a treatment room.
I feel like it's one of those things where we really need to normalize the conversation, and it needs to be right, like, just as a society in general, we need to quit having these taboo topics, and we really do need to make it normal to express what's happening within your own body.
100%. That's a great way to say it. Is we want, it feels like we're always talking about it when we're in a treatment room. I forget sometimes if I say something out in sort of public, that I'm thinking, no, we should all be able to talk like this, right? Like it's okay to use the terminology that's appropriate, and it's okay to talk about these things because it is really normal. And you'd be surprised. You go and have a conversation with a good friend of yours or a family member. They're probably experiencing or have had experienced something similar as well, and you won't feel so alone when you have that conversation. It is all of the things that we've talked about today, are very, very common. So common that this world of pelvic health has exploded, and it's not going away because we really are proving that this is an area that's really important, and it really is comprehensive, and it ties in so many aspects of somebody's health, that yeah, it's not just a flash in the pan. It's been going on for decades now, and we're just going to get better and better at being able to understand and treat patients with anything in the pelvic region.
Well, Gail, thank you so much. This has been a very wonderful conversation, and I really appreciate us being able to dive into, a little bit more about what's normal, what's not normal. Um, I just like took so many takeaways with 2 young daughters at home. I feel like, again, back to that conversation, start early with the conversations around everything to do with like bowel movements and eating fiber, drinking. I'm a slave with them. I'm like, "Drink your water, make sure you're hydrated." So, but I
Yeah.
think it is, I think, right? Like, it's important to make sure you're having those conversations and opening the door to invite discussion where it needs to happen.
Yeah, and that's beautiful. And the more we have a generation that is okay talking about it, the sooner we could probably treat anything that might come up for them, and it's not becoming a lifelong problem anymore. And that's, those are easier to remedy often, right?
Yeah, absolutely. Well,
Hmm.
thank you so much. I really appreciated the conversation, and I know there's a lot of great tidbits for anyone who's listening to take away today.
Thank you so much for having me.
We just had a great conversation with Gail about a topic we just don't talk enough about: pelvic health. If you're interested in learning more about physiotherapy or to find a physiotherapist near you, visit albertaphysio.com. See you next time.